Any questions anyone thought of on break before we get back to chapter 13? No? All right. Then we will get started on talking about shaving. So, assisting residents with shaving depends on what facility you work in for what types of razors are allowed in the facility. For example, in the Jerry Psych facility I worked in, we only allowed electric razors, no safety razors or disposable razors for obvious reasons. So, different types of razors are used differently. Some of them require water and soap or shaving cream, some of them do not. Safety razors and disposable razors, typically soap and water or water and shaving cream are needed to help provide some sort of barrier between the skin and the blade. Electric razors are used without soap, water, shaving cream. This type of razor is rechargeable and reusable, and the chance of actually cutting the skin with this razor are very minimal. So it's a safe type of razor to use, especially if you have someone who has a cognitive impairment or maybe some sort of bleeding disorder. Other things you might see with grooming, pediculosis is the medical term for lice, and then dandruff. Dandruff is just dead skin cells that flake off of the scalp. One unfortunate thing about lice and dandruff is they look similar. So if you ever see something like this, you would bring it to the attention of the nurse and they could further assess to see what it is. When you're assisting residents with grooming, let them make choices, let them do as much as they can. Make sure that you follow your facility's policy for nail care. Some facilities allow nursing assistants to clean and file the nails. Some facilities only allow the nurse to do nail care, so know what that policy looks like where you work. Any observations that you make about the nails, especially toenails, report those to the nurse. Also, make sure if you're going to be coming into contact with any bodily fluid, like when you're shaving a resident, please wear gloves. And like I said, when we were talking about shampooing hair, please be gentle when you are assisting residents with grooming. You don't want to cause them any pain. If your facility allows you to do nail care, it's typically just cleaning underneath the nails with an orange stick, like you can see in this picture, and then filing the nails. Usually clipping the nails is the responsibility of the nurse in any facility. Caring for the feet, really important to report any observations that you make, like any red areas, especially the heels, the tops of the toes. If there's any non-intact skin, looking between the toes, making sure if there is anything that it gets reported promptly. A lot of times for residents, they maybe can't reach their feet, they can't really see very well, so they may not be able to detect an issue if one does arise. Providing foot care, we'll watch a video for this as well. It, again, depends on your facility. When I worked in the Jerry Psych facility, we had a contracted company that came in once a month and did foot care. So they would care for the feet, the nails. As we get older, our nails become more thick. So they would actually bring in a special Dremel tool to file down the nails instead of us trying to clip through those. So if your facility has that sort of service, great. If not, you might be providing foot care, usually just cleaning the feet, washing and drying them, applying lotion, making sure that if there is anything to report about the toenails or any redness or anything like that on the feet, that it gets reported to the nurse. One thing to keep in mind with foot care, and you'll see this in the video that we watch, you never want to put lotion between the toes. Reason being is because between the toes is typically a warm and moist environment. If we put lotion in there, that can allow for bacteria to get in and cause an infection, something like athlete's foot. So if you're putting lotion on the foot and you accidentally get some in the toes, it's not the end of the world. You can just kind of wipe them out with a towel. Just make sure to wipe all the lotion out so that there is not that increased risk of infection. In terms of shaving a resident, if you have never shaved your own face before, very important to pay attention to the way that the hair grows. So if we shave against the way that the hair grows, that leads to ingrown hairs. If we shave with the way that the hair grows, that helps to decrease that likelihood. Make sure that we are only using facility approved products. Again, it'll depend on your facility for what type of razor is used. If you do use a razor with a blade, like a disposable razor, never attempt to put the cap back on that razor. Make sure that the razor itself gets into an acceptable disposal device, like a sharps container. Also, one thing to note with electric razors, they are not to be used near water or if the resident uses oxygen. Little tip for you, if your resident uses aftershave, please wear gloves to put on their aftershave. Please wash your hands after. You do not want to get that stuff on your skin or in your eyes. It will burn. So here is a nursing assistant shaving a resident's face here with what looks like a disposable razor. And here's a resident using an electric razor to shave their own face. Moving on to grooming the hair, residents get to choose their own hairstyle. So ask the resident how they want their hair styled. If they don't have a preference or maybe they're not able to tell you, just make sure that you style it in a way that is not childish. For example, we wouldn't put like 2 big giant pigtails off the sides of their head, right? That's a childish hairstyle. So be aware of that. Be gentle when you're combing or brushing the hair. If your resident reports pain when you're brushing the hair, maybe try getting the hair wet using like a detangler if you have that. Checking the scalp, making sure that there's no non-intact skin. Maybe there's some sort of bruising or bleeding or something happening on the scalp that's causing pain. Make sure to report that to the nurse. Any questions with shaving or hair care? Or nail care? No? All right, we will pull up another lovely video on foot care. So skills video number 19 on foot care. Pay special attention to the fact that we do not put lotion between the toes.
Hi, Ms. Bragg. My name's Betsy. I'm your nursing assistant today, and we need to wash your feet. Okay.
Privacy is provided with a curtain, screen, or door.
Privacy curtain call. Wash my hands. Lift your leg for me.
Before washing, the candidate checks the water temperature for safety and comfort. They check with their elbow to ensure the ease of glove donning later in the skill. They then ask the client to verify the comfort of the water.
Okay. Wash my hands.
The candidate puts on clean gloves before washing the foot. Basin is in a comfortable position for client and on a protective barrier. The client's bare foot is submerged in the water.
Put your foot down. That feel comfortable? Mm-hmm. Like that? Okay.
candidate applies soap to the wet washcloth. The foot is then lifted from the water and washed, including between the toes.
I could use a foot bath like that.
Put your foot back in for me. Toes here. Go ahead and pull your foot out. Sit down.
The candidate then dries the foot, including between the toes.
Go between your toes here. Feel dry? Mm-hmm. Okay. Would you like some lotion? Yes, please. That's better.
Lotion is then applied to the top and bottom of the foot, removing any excess if needed with a towel. Lotion should not go between the toes in this step. All the while, the foot has been supported along with the ankle during the procedure.
Put up.
The basin is then emptied, with the contents going into the bedside commode. After rinsing and drying the basin is placed in the designated dirty supply area. After cleaning foot and equipment and disposing of used linen, removes and disposes of gloves without contaminating self into waste container and washes hands. The candidate ensures the signaling device is within reach.
Make sure the bed is locked and out. Open the call light. Open the curtain. That's your call light. I would wash my hands, and the skill's complete.
Any questions on that one? Pretty simple, just don't put lotion between the toes is the biggest thing. All right, moving on to dressing. So when we're helping someone get dressed, it's important to know if they have an affected or involved side, if they've had a stroke. If they do have a side that is weaker than the other, we need to know what side that is in order to prepare for getting them dressed. Terms that we can use for the affected or involved side are affected, involved. We wouldn't want to use something like useless or the side that doesn't work. We don't want to apply any negative terms to that side, so always watch what you call it. You could say, the weaker side, that's okay. As far as clothing goes, follow resident preference. Allow them to pick out their clothes. Encourage them to wear day clothes during the day hours and night clothes during the night hours. Allow them to do as much as they safely can for themselves. Residents who are able to assist themselves with dressing, there are lots of assistive devices that can help them get their socks on, their shoes on. Things like front fastening bras are easier to put on. Pants with elastic waistbands are easier than some with zippers or buttons. Sweaters that maybe don't have 50 buttons to get them secured, maybe a zipper is a little bit easier. If you are dressing someone who has an affected side, start with the weaker or affected side first when you are dressing them. When you are undressing them, you want to start with the opposite or the stronger side. That way, we're never putting that weak or paralyzed side into an odd position. So making sure that we get that one dressed first and then undressed last. There's pictures in your book of all sorts of different adaptive aids that make getting dressed easier for residents, so you'll see those when you do your reading. We will watch a video on dressing a resident so that you can see what that looks like. Dressing, there we go. So this is dressing a resident with an affected side. So pay attention to how the clothing is put on and then how the other clothing is removed.
Hi, Miss Bragg. My name's Betsy. I'm your nursing assistant today, and I understand you want to get dressed.
Yes,
And I understand your right arm doesn't work so well.
correct.
Okay.
Privacy is provided with a curtain, screen, or door.
Privacy curtain. Remove this. I'm gonna wash my hands. I'm gonna go get some clothes for you. Which shirt would you like
The
to wear?
candidate
Got the
asks
flowers or
which
got the
shirt
black?
the patient would like to wear and dresses the patient in their shirt of choice.
Okay. Hold this up. Okay, if you would use that arm to go ahead and hold on to that sheet. for
While
me.
avoiding overexposure
On
of
the other
client,
side.
the candidate removes the gown from the unaffected side first, then removes the gown from the affected side, and disposes of the gown into soiled linen container.
Go ahead and hold back onto it. Hold on tight. Pull this out from underneath. Okay. Put your arm in here.
A critical step, the candidate assists to put the right, which is the affected arm, through the right sleeve of the shirt before placing garment on left unaffected arm.
Holding on tight. If
While
you can
putting
sit
on
up
shirt, moves body gently and naturally, avoiding force and overextension of limbs and joints.
and lay down. There we go, a little better. Okay. That arm up for me, please. Put your arm in there. There we go. Button up here.
For this skill, only 2 or 3 buttons at the top of the shirt need to be fastened. Ensuring that the candidate finishes the skill with clothing in place, the signal device is given to the patient, and the bed is in low position.
There you go. I would wash my hands, and the skill is complete.
Okay. So think about if the resident is able to dress themselves, they're able to put on a shirt or pull up their pants. Think about the types of clothes that are going to be easier for them to utilize. So in my experience, a lot of times when residents are maybe their condition's getting a little worse, they're starting to get dementia, it's harder for them to do up buttons and zippers. So if we could promote that independence and they can dress themselves just by maybe asking their family to bring in elastic waistband pants or maybe shirts that pull over instead of button up. We want to make sure to bring that to the attention of the nurse. That makes it easier for them. It also allows them to practice that independence. Moving on to oral care. Oral care is caring not only for the teeth, but also the inside of the mouth and the gums. Flossing is part of oral care that we provide, so using a piece of dental floss to clean the surfaces between the teeth. The medical term for bad breath is halitosis. If we say someone is edentulous or you see that in their care plan, usually that just means they don't have teeth. They might have dentures. So if you look at them and you're like, they definitely have teeth, they could potentially be false teeth. We'll come back to aspiration here in a second. So when you're providing oral care, again, observing, looking for any irritation in the mouth, any discharge, bleeding of the gums, sores, any issues with the teeth, any reports of pain in the mouth. We want to report all those things to the nurse. If we're providing oral care to someone who has their own teeth, obviously we're going to brush the teeth in their mouth. If we're providing oral care to someone who has dentures, we're going to clean out the oral cavity and then go ahead and remove the dentures to clean those separately. We'll go through that here in a second. If we're caring for a resident in a more acute care setting, maybe they're unconscious, we provide oral care a little bit differently. Reason being is because we do not want them to do what's called aspirate or inhale the contents of the toothpaste and the water into their lungs. Aspiration, bringing in foreign bodies into the lungs, just leads to infection. So for someone who's unconscious, we want to use as little liquid as possible. We want to position them appropriately, which is typically on one side or the other. That way any liquid can just kind of leak out. We usually don't use a toothbrush and toothpaste. Usually what we use is called a swabette. It is a little swab, looks like a little sponge on a stick, essentially, something like this. And usually they are unflavored, so it's just like a little sponge on a stick that you would dip in some water. Some of them are flavored, like mint flavor, what have you, bubblegum flavor I've seen as well. And we use this to wipe all the inside surfaces of their mouth. The reason we don't need a toothbrush and dental floss is because if they're unconscious, they're not eating. So we're just ultimately trying to moisturize and clean those surfaces. When you are providing oral care, please make sure that you are wearing gloves. Remember, saliva is considered to be a bodily fluid, so we don't want to touch that with our bare hands. When you're flossing the teeth, be careful, be gentle. If you don't know how to floss, here's the procedures. We're not going to go through them now, but if you want to come back and review them, you can do that at a later time. Like I said, if someone has dentures, that's just a false set of teeth. Their dentures need to be cared for as well, so we don't brush the dentures in the mouth. Instead, we take out the dentures to clean them. Please know that dentures, along with many other adaptive and assistive devices, are very expensive. Obviously, dentures are custom fit to your resident. We need to be handling them with care. If they're missing, they don't fit, they're broken, something is wrong with them, please report that to the nurse. Probably doesn't seem like a big deal if their dentures are, missing or what have you, but they can't eat if they don't have teeth, right? If they don't have their dentures in, they're not going to be able to chew their food, and then they're going to become malnourished. So they are a very important part of the resident's life. Dentures do come into contact with bodily fluid, so please make sure that you are wearing gloves when you handle dentures. Also know that things that can harm dentures are hot water. Also, pay attention to what's recommended to clean them in the care plan. Some dentures can be brushed with a denture brush and paste. Some of them need to be soaked in a denture cleaning solution. So pay attention to the instructions there in the care plan. Anytime a denture comes out of someone's mouth, it should go into a labeled container. Like I said, residents like to take their dentures out and store them under their pillow. I've also seen residents put them in their pocket, so their dentures are in their clothing pocket. So check pockets, check bed linens before you go to put them in the wash. When you clean a denture, it's important to line the bottom of the sink. That way, because you have on a glove, you got a slippery denture and toothpaste and a toothbrush. If you drop the denture, it doesn't break. So really important to put like a washcloth, a towel, something down in the sink that will catch the denture if it does fall. Like I said, follow instructions in the care plan for cleaning. Some of them you brush with a paste and a brush. Some of them you just soak in a cleaning solution. Some residents may have some of their own teeth and potentially what's called a bridge in their mouth. A bridge is essentially if they're missing like one side of their teeth, a bridge will attach to the teeth they have and it will provide false teeth between the two. So follow the instructions in the care plan on caring for those. If a resident has implants, those are false teeth actually implanted into the jaw. So if they have implants, follow instructions for caring for those. It's typically very similar to how you would normally brush teeth. Any questions before we take a look at a couple more videos? Nope. All right. Then we will pull up a few more videos here. So we have, where did it go? Here we go. So here is the denture video, so skills video number 5. Cleaning a denture.
The bottom of the sink is lined or partially filled with water before the denture is held over the sink.
Okay, I will wash my hands.
The candidate puts on clean gloves before handling denture. Before placing denture into cup, the denture cup is rinsed and the lid is rinsed. The candidate rinses denture in moderate temperature water that is running before brushing them. Toothpaste is applied to the toothbrush or denture brush. All surfaces of the denture are then brushed. The toothbrush is then rinsed and placed in designated toothbrush basin or container. After brushing all surfaces, the denture is rinsed under moderate temperature running water. The denture is then placed into the denture cup with moderate temperature water and places the lid on the cup. All the while, the candidate has ensured clean technique has been maintained with placement of the toothbrush and denture. At this time, the sink liner is removed and disposed of appropriately, and/or the sink is drained. After rinsing equipment and disposing of sink liner, removes and disposes of gloves into waste container and washes hands.
Would wash my hands and the skill's complete.
Any questions on that one? Nope. All right, then we will do this one on mouth care, and then we will get back to starting chapter 14.
Hi, Miss Bragg. My name's Betsy. I'm your nursing assistant today, and we need to brush your teeth this morning.
Privacy is provided with a curtain, screen, or door.
Privacy curtain. Okay. I'm gonna sit you up on the side of the bed here. I'll wash my hands. Come back.
Before providing mouth care, the client is in an upright position of at least 75 to 90 degrees. To ensure this, we ask the client to sit at the edge of the bed and assist them into this position.
Okay.
A clothing protector is placed across the chest of the client before providing mouth care.
Wash my hands.
The candidate then puts on clean gloves before cleaning the mouth. The candidate secures a cup of water and moistens the toothbrush. Before cleaning the mouth, toothpaste is applied to a moistened toothbrush. A critical step, the mouth is cleaned, including tongue and all surfaces of the teeth, using gentle motions. All the while, the candidate maintains clean technique with placement of toothbrush.
Say for me. Stick your tongue out for me. Okay. One more spit.
Holds an emesis basin to the client's chin while the client rinses their mouth. The candidate wipes the client's mouth and removes the clothing protector.
You want to get back into bed?
After rinsing the toothbrush, empty, rinse, and dry the basin. The contents of this basin can be emptied into the sink or the toilet or the bedside commode. Place the used toothbrush in the designated basin or container. Places basin and toothbrush in designated dirty supply area. The candidate removes and disposes of their gloves without contaminating themselves. They then wash their hands and ensure the signaling device is within reach and the bed is in low position. With this skill, we have asked the client to sit at the side of the bed. We need to also ensure they are assisted back into a lying position in bed.
Open up the curtain, wash my hands, and the skill's complete.
All right. Any questions before we move on to chapter 14? All right, so chapter 14, we're going to go over basic nursing skills. We're going to start looking at vital signs, which is measurements that we can take that will tell us how different internal organs are doing without us actually having to visualize them. So vital signs include temperature, pulse, respiratory rate, blood pressure. Also, pain level is another vital sign that we check. We want to report if we check vital signs and anything is not within the normal limits. So we will look at the normal limits, and then if you checked a vital sign and it was not in those normal limits, you would report it to the nurse, whether it was low or high. Temperature, there are 5 different routes that we can check a temperature. Each has a little bit different of a normal range. So it's important to know the normal range for the route that you will be checking the temperature. That way, when you get a reading, you know if it is needing to be reported to the nurse or not. I showed you the other day these little cards that I used to carry in my pocket, like so. This is a great place to put normal values and keep it in your pocket until you memorize them. So if you want to write those all down on a little card, you can laminate it. You can also use like clear packing tape to kind of laminate it as well. And then you can keep it with you in your pocket. That way you have a reference until you get them memorized. Normal values for adult blood pressure readings. The only ones I want you to pay attention to here are the normal readings, the low readings, and the elevated readings. The rest of those you don't need to memorize. You should know if you check a blood pressure and it's, let's say, 128 over 88. You would know that that is elevated, right? That is not within the normal range we would expect, and then you would report that to the nurse. Keep in mind, if you're checking vital signs, we don't want to violate HIPAA, right? We don't want anyone else to know what someone's vital signs are. We also want to protect their privacy. So the best place to do vital signs is to get a resident to a more private area, like in their room, or over by the nurse's station is fine. You wouldn't want to go into an activity or into the dining room and start checking someone's vital signs. That doesn't give them the privacy they need. As far as body temperature goes, like I said, there are 5 sites we can check this at. There are some reasons that we would not use certain sites for certain people. For example, we wouldn't use the oral route if someone is confused. They might try to eat the thermometer. We wouldn't use that for children or anyone who has had some sort of injury to their face. Keep in mind that thermometers differ based on what your facility stocks from what manufacturer. Most thermometers are approved for use multiple times. They're not disposable. In the event that there's an outbreak of an illness in your facility, you may utilize disposable thermometers. Thermometers that are used for oral temperature checks, axillary temperature checks, and rectal temperature checks are very similar. So pay attention to color coding. Usually a rectal thermometer is going to be red. So you would know that if you were checking a rectal temperature, you would use the red thermometer. If you're checking any other temperature, you would not. Sometimes the oral and axillary ones are blue or green. Most thermometers we use these days are digital. So you put it into the cavity, the mouth, the ear, what have you, and it tells you a temperature. There are different routes that we use thermometers to check a resident's temperature that require different levels of skill and practice. Tympanic thermometers, the ones that go in the ear, require a little bit more practice to get an accurate reading than something like an oral thermometer, where you just basically put it in the mouth, seal the lips, and you get a reading. The most accurate way to check a temperature is via the rectal route, but that is not our preferred method of temperature check, right? It's very invasive. There's also some risk for injury with a rectal thermometer, so not what we rely on, but it is the most accurate. Axillary temperatures are considered the least accurate because if we put a thermometer in the armpit, if the armpit is sweaty, that could potentially sway our results. So that is the least accurate reading. Any thermometer that we use in a facility needs to be cleaned between residents. And some thermometers actually have a protective covering that you use. So you would use it for the resident, dispose of it, clean the thermometer, and then get a new protective covering for the next resident. When you are measuring temperatures in your facility, please know what route your facility prefers that you use. Also know what thermometers are available for your use. It's really important that we know how to use the thermometer, because if we don't know how to use the thermometer or we use it incorrectly, we could potentially get a false reading. Give me 1 second, I'll be right back. All right, sorry about that. Had to take that phone call. So back to temperatures, way more interesting things. So pay attention to what route your facility prefers, and also pay attention to what thermometer they have. Practice using that thermometer before you try to check a resident's temperature. The thing to know with oral thermometers is they're usually digital these days. We don't usually have these mercury-filled thermometers because guess what? They weren't safe, so we did away with them. So typically you just clean the thermometer, put the protective covering over it, put it in the resident's mouth, it beeps and gives you a temperature. We will practice in your workbook looking at a manual thermometer. They're pretty much obsolete, but we will still practice just in case you do need to use one. So you'll get to see this in your workbook. We won't go through these now. So you're probably thinking, if a rectal temperature is the most accurate, but we don't really prefer that route, why would we use that? The only reasons that we use a rectal temperature is if the resident is unconscious, they have some sort of issue in the oral cavity, or they cannot breathe through their nose while a thermometer is in their mouth. Now, we only resort to the rectal temperature if we don't have some sort of temporal thermometer. Temporal thermometers in this day and age are pretty common. Those are the ones you just scan across the forehead and it gives you a reading. So if we don't have one of those for some reason, we could then resort to a rectal temperature. Make sure that if you are checking a rectal temperature, you always explain what your procedure is going to be to your resident. Also, make sure that you know how to utilize the thermometer. You will need lubricant to insert the thermometer into the rectum. You also want to know that in the when we have something in the rectal cavity, we do not want to let go of it. It can puncture the wall of the rectum, so it's really important that you are present to hold the thermometer until it is finished checking the temperature. Obviously, since we're coming into contact with the rectal area, we're wearing gloves. And obviously, since we are exposing the resident's rectal area, we need to provide privacy. So we looked at different positions, and one of them was Sims position. Checking a rectal temperature is one that we would use that Sims position for. And we'll talk more about some other reasons why we would use that position on Monday. So there's that Sims position, that left side lying with the right knee flexed. Using a tympanic thermometer, that's the one that goes in the ear. The tympanic thermometer is the quickest at giving us a reading. It only goes into the ear about 1/4 to 1/2 inch, and like I said, it does require some practice in order to get that correct. Axillary temperatures, again, the least accurate. Before we had temporal scanners, we used to use axillary thermometers and check the temperature that way for all the residents in Jerry Psych. When you utilize a tympanic thermometer, for an adult, you position the ear in an up motion. So you hold on to the ear gently, of course, and you pull the ear up. That will give you a straight shot to the canal, which you put the thermometer in, and then you will press a button and wait for it to beep. So that's what takes the practice, is actually getting the ear in the right position and then getting the thermometer inserted far enough, but not too far to actually get a reading. If ever you check a temperature and you're like, what in the world, this does not seem accurate, try it again. It's probably not accurate. Maybe something went wrong and you didn't have the resident positioned properly, or you didn't leave it in long enough, or what have you. So always double check yourself before you go to the nurse and say, oh, their temperature is 92 degrees. No, because they'd be dead. So make sure that you recheck if something doesn't seem right. Any questions on checking temperatures? No? All right. Moving on to pulse and respiratory rate. So when we check a pulse, typically as a nursing assistant, we are checking the radial pulse. The radial pulse is located on the inside of the wrist. It is right above the radial artery. That's why it's called the radial pulse. We can also use what's called the brachial pulse. We don't usually use this one just for checking the pulse. We use this one as we take a blood pressure. Another type of pulse that you might see is called an apical pulse. The apical pulse is actually just listening to the heart on the left side of the chest, just below the nipple line. And how we would listen to an apical pulse would be by using what's called a stethoscope. So a stethoscope looks like so. The stethoscope usually has a tube in the center to transmit sound. It also has these ear pieces at the top that kind of look like little bunny ears. And then at the bottom, it has this device that helps us to amplify sound. You'll get to use your stethoscopes in clinical, but I just want to give you a few pointers, things that you can start to think about. The little bunny ears of your stethoscope here, they point either forward, so like this, or backward, like this. You always want your bunny ears pointing forward so that they fit into your ears. So this little device, you can kind of see how it's pointing down. Those should be pointing forward to get them positioned in your ears. So that is how you put this thing on. This little device at the bottom, all stethoscopes are created a little bit differently, so it depends on what you have, but it has an amplifier. This little piece here is called the bell. So the bell is placed on the patient or the resident, and it amplifies the sound through the tube and up to your ears. One thing to note about the bell is that it can be turned off. So if ever you put your stethoscope on and you put the bell on the resident and you're like, I can't hear anything, turn the head of the bell. So it turns on and off. If it's off, you're not going to hear anything. If it's on, you will. So troubleshooting for your stethoscope there. Does anyone actually have their stethoscope that they have picked up yet? Yeah. So play with it tonight. I mean, don't play with it, but, test it out. Try putting it in your ears, putting it maybe on your own heart, listening. If you have animals, you can listen to them. If you have children, listen to them. You don't need to know what you're listening for. You're just practicing, making sure that the thing works, making sure it's comfortable in your ears. All right. I've been through multiple stethoscopes in my time because animals really like stethoscopes too. They're fun devices. I think that's like my third or fourth one. So keep yours away from your animal. That would be my biggest point of advice, probably from children also. So moving on to the pulse. The radial pulse, like I said, it is inside of the wrist and we feel it. So we touch it and we are able to detect it that way. What we are detecting when we're counting the pulse is how many times in a 1 minute period that the heart beats. For an average adult, the heart should beat between 60 and 100 beats per minute. For children, it is beating more per minute than for adults, but for our purposes, we're only wanting to know the normal for adults. Pulse can be affected by a lot of things. For example, if you go out into the heat or you exercise, your pulse tends to increase. Pulse can also decrease for various different reasons, maybe an infection. There is a picture in your textbook of all of the different sites. We're also going to look at some pictures here, and I'll point out what site you're actually looking at. So here is a nursing assistant checking an apical pulse. So, whoops, come back. Apical pulse, again, is the one that you actually have to listen to with your stethoscope. You can see that the bell of the stethoscope is placed on the left side of the chest, just below the nipple. And the nursing assistant is listening to the heart rhythm here. So what they're listening for, and you can practice this listening to yourself later, is they're listening for each lub-dup, lub-dup. Each lub-dup is one full heartbeat. While they are calculating this, they are needing to monitor it for a full 60 seconds. So you need a watch to be able to calculate that whole 60 seconds, what the apical pulse is there. As far as respiration, we'll look at a couple more pictures of pulse here in a second as well. Respiration ties closely to pulse because when we are checking the pulse, before we finish checking the pulse, once we get our value, we can actually check the respiratory rate without the resident being aware of that. Reason for that is because if you tell someone that you're watching them breathe, they probably aren't going to breathe normally, right? If I told you right now, I'm watching you breathe, you'd probably be like, uh-oh, do I take a breath now? Do I not? Do I breathe fast or slow, right? So we don't want the resident to be aware of the fact that we're watching them breathe. The only time that you want to point out that you are watching someone breathe is in your state exam, because you want the examiner to know that you are checking respirations. So make sure for your state exam that you say, okay, I'm going to check the respirations now. But for residents, I'll show you kind of how you can play off like you're checking the pulse while actually checking their respirations. So again, little review on respirations. Taking a breath in is inspiration. Taking a breath out is expiration. 1 inspiration plus 1 expiration equals 1 breath. So that's what you're counting. A couple more medical terms here. Ones that I would know: dyspnea, which means difficulty breathing, and then apnea, which actually means that there is no breathing. That is the absence of breathing. Other medical terms, I don't expect you to know all of these upon completion of your course, but if you see them, for example, in the care plan, you could say, oh, I think I've heard of that before, and then you can look it up at that time, and that allows for you to learn. So tachy always means fast. Tachypnea is fast breathing. Brady always means slow. So bradypnea is slow breathing. We'll talk more about Cheyne-Stokes when we get to hospice. So again, each respiration is a breath in and a breath out. That together is 1 breath. Normal rate of breathing for adults is 12 to 20 breaths per minute. Again, infants and children tend to breathe faster, but for our purposes, we're looking at adults. So what you do is you are counting the radial pulse, and instead of stopping or removing your hand from that radial area, which is here, you just hold your hand there after you're finished and you watch the resident's breathing. So you can see this nursing assistant. If we look, it looks like he's still checking the pulse, right? But he's actually already checked the pulse, and now he's watching the respirations. So you can make it so that the resident is not aware of what you are watching. So practice, and again, you'll get to practice lots in clinical as well, but practice locating your radial pulse. You can also practice locating family members' radial pulses. Don't expect you to be an expert yet, but just to get an idea of what your skills are going to look like. Any questions about pulse or respiratory rate? Yeah, Samantha?
Is there any situation where you would have to use like the femoral pulse?
Very rarely. But yeah, there are a lot of different pulses. So femoral pulse would be in your thigh near your femur. There's the popliteal pulse. There are pulses in your feet called pedal pulses. So there's a lot of different pulses. The reason that we typically use the radial, if possible, is because it is easy to access, right? If you can access someone's wrist, even just pulling up their jacket, pulling their sweater out of the way, it's easy to access. You don't have to expose them. If you couldn't detect a radial pulse, I would definitely have the nurse come and help. We would then start moving to maybe the brachial pulse or listening to the apical pulse. But there are some instances or some reasons why we may need to move to some of those other locations as well. It is difficult. It is a very specialized skill to try to find a femoral, a popliteal, and a pedal pulse. So the 3 in the lower half. Those ones are harder to detect, harder to locate. They're a little deeper than, for example, the radial pulse. So if you couldn't detect the radial, I would have the nurse come and assist.
Okay, cool. Thank you. We just use that on animals. So I was just wondering.
Yeah, on animals, see, I don't even know all the pulses on animals. I actually just learned like a couple weeks ago, our dog had an abscess in her foot from some place that we had gone, apparently. She got some sort of infection in there, and they had me feel her popliteal lymph node. And I was like, oh my gosh, that thing's huge. And they're like, yeah, it should be like an eighth of that size. And I was like, oh no. So I don't know exactly where all the pulses are in animals because, like I said, not my thing. But yes, that is another location that is also on humans that we can use. It's just a little deeper. It's harder to find. It's also kind of invasive, right? If you got to go in someone's groin to find a pulse, it's like, probably better places we could check it. Good question. Also important to know when you are checking a pulse, when you are actually detecting it with touch, so the radial pulse, you want to use your first finger, your index finger, and your middle finger. So these are the two fingers that you should use to detect that pulse. And the reason is because some of your other fingers have a pulse of your own, and you don't want to be recording your pulse. You want to be recording the resident's pulse. So first and second fingers are the best to apply to the wrist to check the radial pulse. All right, moving on to blood pressure. So we went over what systole or the systolic blood pressure and diastole or the diastolic pressure are. Remember, the systolic pressure is the higher number because it is when the heart is working. The diastolic, the bottom or the lower number, is lower because that's when the heart is at rest. So when you check a blood pressure, that's what you're actually detecting. You might see a medical diagnosis in a resident's care plan called hypertension. It's abbreviated HTN. This just means that the resident's blood pressure readings are consistently high. So the doctor may have diagnosed them with this, and they may have them on some medication to help. Hypotension is the exact opposite, so blood pressure readings are consistently low. How we actually detect a blood pressure is, of course, by using our handy-dandy stethoscope, but also by using a blood pressure cuff. Blood pressure cuff is also known as a sphygmatometer. I would recommend just saying a blood pressure cuff because it's easier. So blood pressure cuffs, this one also was taken by a dog, so it is not calibrated any longer, but just to show you what they look like, this is a regular adult cuff. So here is the cuff. Here's the actual sphygmatometer, the little measuring device. It's attached to a tube with a bulb at the end that allows for you to inflate the cuff. So if you have your blood pressure cuff from school, don't try to use it until you receive that training in clinical, just because you can actually do harm with it. But I just want to show you basically what it looks like and let you know that you will be using it in clinical. Another device that we oftentimes use in healthcare is called a pulse oximeter. A pulse oximeter is a non-invasive way to measure someone's oxygen saturation. It actually uses a little light to shine through and detect how much oxygen is circulating around in your blood. In long-term care settings, we typically use portable ones like this. So what happens with this is you open it up, you turn on the power, you stick the resident's finger in, and it will give you a reading. I'll see if it'll give me a reading, and then I'll show you. Come on, little thing. It's thinking about it. One thing to note with these, they take batteries. Batteries go in here. It's like a couple of AAA batteries. If the battery is low, the thing doesn't work. Also, if the fingers are cold, the thing doesn't work. And if there is dark nail polish, it will not detect oxygen level. There's a couple of things you can do for that if it's not working properly. Like, for example, it gives you a crazy oxygen reading and you're like, what in the world? That's not possible. Change the batteries. If it won't read due to a cold hand, run the resident's hand under warm water. And if it won't read due to dark nail polish, just twist the thing sideways. That way it's reading through the opposite side of the finger instead of trying to get through that nail polish. So troubleshooting for it. All right, it looks like it's thinking about giving me a reading. If it doesn't, ultimately, maybe. Oh, there we go. It is showing you that top number, that 98%, that is oxygen saturation level. And then the bottom number is heart rate. The only thing with these and monitoring heart rate is they're not reliable, because if I sit here and do this, my heart rate's going to increase on here. Also, if I'm talking, my heart rate is going to increase on here. So typically facilities will allow you to use this to monitor oxygen saturation, but they still want you to check the pulse or the heart rate using that radial method. So as far as the blood pressure goes, we looked at the normal ranges. Remember that if a blood pressure reading is ever not in that normal range, you would report that to the nurse. You'll get to see in clinical how to position the blood pressure cuff and the stethoscope. Ultimately, the blood pressure cuff goes on the upper arm, which we'll see a picture of here in a second, and the stethoscope is placed on the inner side of the elbow, just above, about an inch or two above, to have that positioned on the brachial pulse. So you're actually listening to the brachial pulse while that cuff is deflating. But like I said, don't worry too much about it yet. You'll get to practice lots in clinical. There are some situations that our residents might be in that we would not want to use a blood pressure cuff on their arm. Those are reasons like they have an IV in that arm, some sort of medical equipment, dialysis shunt in that arm. Their arm is in a cast, or they have some sort of recent trauma or surgery to that arm. If they have a burn, if their arm is paralyzed, for example, maybe they've had a stroke, or if they have had a mastectomy, which means removal of the breast tissue on that side. So if that's the case, check the blood pressure on the other arm. If they've had, for example, a double mastectomy, or they have burns on both arms, then check with the nurse before you check the blood pressure. Also, one thing I want you to know about checking blood pressures is it's easier said than done. It takes a lot of time and practice to master the skill of listening while you're blowing that cuff up and deflating it, and remembering what the top number and bottom number are. So it takes a lot of practice. It's not something that's just you're going to go into clinical, you're going to do it once, and you're going to be a professional. So keep that in mind. It's something that takes time. So here is a picture of what that blood pressure cuff looks like positioned on the arm. You can see that the cuff is wrapped around the upper arm. Then here's a picture of the stethoscope placed on the inside of the elbow there on that brachial artery, so that the nursing assistant can listen for the systolic and diastolic readings. Some facilities will have automatic blood pressure cuffs. So some of them are wrist cuffs, some of them are upper arm cuffs. If your facility uses those, just make sure that you know how to use them. The most accurate type of blood pressure reading, of course, is going to be with a manual blood pressure cuff and a stethoscope. Any questions so far on blood pressure? All right. If the nurse tries to delegate a task to you called orthostatic blood pressure measurements, that is something that you can do. It is just checking the blood pressure when the resident is in a couple of different positions. So first, we take a blood pressure with the resident lying down. Then the resident sits up. We check the blood pressure then. And then when they stand up, we check it again. So we get 3 different blood pressure readings. What that's telling the nurse or the doctor, whoever is asking for it, is ultimately if that resident is experiencing that imbalance that we talked about, that may cause them to faint when they stand up. So if their blood pressure is evening out every time that they're changing positions or not. Any questions on the use of the pulse oximeter? Usually, this is what you would have in long-term care. If you're in a hospital setting, you may also have an oxygen sensor actually attached to the resident. It's usually just a sticker that's placed on the finger, and it stays on that resident for the duration of their stay. So it's a more permanent device, whereas the portable ones, we just put them on, get a reading, and take them off. Just a reminder, I'm looking at a couple of your ceilings and walls. You don't get credit for being here if I'm not looking at you. All right, so now moving on to pain. Pain is another vital sign that we monitor. Pain is important to monitor as a vital sign because a lot of times residents don't report pain to us. So they may think like, oh, it's not that bad, or oh, it's normal, or oh, she's really busy. I'm not going to bother her with my pain. So it's important that we ask about it when we check vital signs. If we do find out that the resident is experiencing pain, that is something that we would then report to the nurse. Before we make that report, some things that might signal that the resident is in pain, even if they don't say so. Changes in vital signs, especially increased vital signs. So if the blood pressure is high, the pulse is high, and the respiratory rate is fast, that could be a sign that they're in pain. Also, sweating, guarding a body part. Like if I was sitting here doing this, you might ask, what's wrong with your wrist? Well, it hurts. Grinding the teeth or clenching the fists, squeezing the eyes shut, tightening the jaw. Those are all pretty good indications that someone is experiencing pain. If your resident is restless, anxious, crying, groaning, rocking back and forth, or pacing, those can also be signs that they're in pain. To help reduce resident pain, we want to make sure we are repositioning them per the care plan, reporting that pain to the nurse. We can do a lot of things to assist them to relieve that pain, like making sure basic physical needs are met, making sure they're comfortable, they've gone to the bathroom. We can make sure that they're in a calm environment. Sometimes they just need a quiet place to rest. And you want to make sure, since pain is one of those things that is very subjective, it is exactly whatever the resident says it is. It is not something we can detect or detect how bad it is. We want to make sure that we are responsive when residents are experiencing pain. We'll come back to sitz bath in the future. Does anyone have any questions thus far through basic nursing skills? No? All right. We are going to stop there because I want to make sure we have time to talk about your presentations, which if you look on your schedule, it says we're going to be selecting presentation topics today. So we will pause on chapter 14 there, and we will switch over to talking about presentations. So where you will find the information that I am telling you is under the resources tab of your classroom. So that is, if you click on classwork at the top, that is under resources. And if you scroll down all the way to the bottom, right here where it says presentation guidelines, that is where you will see this information. You will not see this information until after class. And the reason being is because the first time that we did this, we posted the presentation topics, and then no one listened to my entire explanation of the presentation. They were all just picking their topics. So then everyone's like, wait, when's the presentation? What am I supposed to do? But everyone had a topic. So it will not open until 2 o'clock today. But that is where you will find it when it does open. And what it will look like when you see it at 2 o'clock is there will be a list of presentation topics. You'll be able to type your name into a presentation topic, and then that will be saved. So anyone who opens that up will be able to see it. So don't worry that you have to send anything in or anything like that. It will all be saved automatically. So let me pull these up so that we can see them before they are actually posted. So give me 1 second. Maybe it's thinking about loading. There we go. Okay. So this is what the guidelines will look like when they are uploaded into the classroom at 2 o'clock. We're going to go over them now, just so you have an idea of what to expect for your presentation. If you look, there we go. If you look at your CNA class schedule, you will note that your presentations happen after clinical. So presentation day, you'll log back in here with me, and we will go over your presentations on June 21st. So that's a Wednesday. You'll be presenting just like I do every day. So you'll share your screen, you'll go over your content, and then we will ask questions. So that's when it is. What it will look like is essentially whatever topic you pick, whether it be you decide to give a presentation on diabetes or pressure ulcers or what have you. Your presentation will be set up in the form of like a PowerPoint, or if you're not very tech savvy and you want to do like a poster board, that's fine too. There are a lot of different free applications. For example, Google has Google Slides, which are free, so you don't have to pay for anything like you would to make a PowerPoint. There are also lots of different websites. Prezi is one of them that students have used in the past that allows you to make a free PowerPoint presentation. So lots of options. So with your topic, you will be going through a list of required bullet points to hit in that presentation. So you'll have a PowerPoint full of information, and you will be telling us about your topic. You'll be telling us that information. Each presentation is going to be 10 to 15 minutes long. And then after your presentation, we'll give your classmates 5 minutes to ask you questions. Don't be afraid if you don't know the answer to the question, that's okay. I can always help you if you're not sure. And also, please practice your presentation beforehand, because we do need you to fall within that 10 to 15 minute timeline. If everyone's presentation goes on for 45 minutes, we're going to be here for weeks. So keep that in mind, practice, and try to make sure you're between 10 to 15. One thing to know with these presentations is you should know the topic that you're talking about. You should know all of the content that is in your presentation, because you should be researching to find that information. So anytime you go to look through your book or look for a website to find information, you should read through the information and put the important information that is required on your presentation. You should not go to a website and copy everything there and paste it into a PowerPoint. Usually I can tell when students have done that, because it's not anything that they would have typed up, and also because they have no idea what they're talking about and they don't know how to pronounce any of the words. So please make sure that you are actually researching your topic, learning about your topic, and then giving us that information that you have learned. Presentations are best done on like a tablet or a computer. When students try to share a presentation on their cell phone, oftentimes it completely takes out their internet. So we're supposed to be able to see you, hear you, and see your presentation. A lot of times when students try to do that on their phone, their internet is completely incapacitated. It is not able to do all of those things. So if you do not have a computer or a tablet at home, you can go into the school to do your presentation. They have that available for your use. Did I see a hand up?
No, I was asking about if I didn't have a computer.
Okay, yeah, you can definitely go into the school and you can use one of the computers there to do it. All right. So the topics, like I said, you will see a list of topics provided. You can pick one of those topics, or if you don't like any of the topics, there's a section at the bottom that will say Other. In that section, you can put any topic that you would like to discuss, as long as it applies to human health care. So it needs to apply to the residents we're going to be taking care of. Please don't put something to do with horses or dogs. Though I am very interested, it doesn't apply to our class. So as long as it applies to human health care, you'll be good. Next Thursday at the end of our class, I'll go through, and anyone who has added an other topic, I'll make sure it's appropriate, aka it applies to humans, and I'll sign off on it. Then you'll know you're good to go. After next Thursday, you cannot change your presentation topic. So you need to select a topic and you need to stick with it after next Thursday. So if you pick one and you're like, oh, I want to change it, and the other topic you want to change to is still available, you can change it. It just needs to be done before we end our theory portion. With that being said, each person is going to pick their own topic unless you want to work with someone in your class as a group. If you want to work as a group, you need to both agree that you want to work as a group. You need to agree on a topic, and you also both need to work on not only the PowerPoint presentation, but you also both are going to be presenting parts of your topic. So it's not like, I'll do the PowerPoint and you present it. No, both need to be involved in both parts. Also, if you choose to do a presentation together, please know that you are both responsible for the entire presentation. So if one person decides to do nothing and the other person is left doing all of the work, your grade will show that. So just make sure if you want to work as a team that you're actually going to do so. So what in the world needs to be in this presentation? So the structure of your presentation, like I said, PowerPoint or poster board is fine. You don't have to have a specific number of slides in your PowerPoint. You just need to cover all of these topics. So topics A through F here need to be covered. So first what you'll do is you will introduce us to your topic. You'll explain signs and symptoms and effects on the patient. You'll explain how the illness is diagnosed and by who. You'll explain treatment. Put emphasis on how you as the CNA can help someone who has this condition. You'll explain any issues that can arise and also how you as the CNA can address those issues. If you pick something, for example, like diabetes, and there's lots of different medications, lots of different types of insulins that can be used, you can just pick one. So just focus on one thing. You don't have to go through every single possibility. And then you'll provide us with a summary or conclusion of your topic, and you'll prepare for questions. One thing to know is if you are taking information from anywhere other than your brain, you need to reference it. So if you use a website, copy the website and put it at the end of your presentation. If you use your book, type out you used the Hartman CNA book at the end of your presentation. That way we know if there is any question of where your ideas came from, those were the references that you used. This part at the bottom here for handouts, you don't need that because we're going to be online. So you can go ahead and put a giant X through that section for handouts. The only thing that you need is just your references if you use them. Any questions on the setup or structure or sections of the presentation? No? The purpose of the presentation, if you're curious, is to prepare you to talk to residents. So helping you to be able to kind of speak to your classmates. It's nice because you're at home, right? So you're not standing in front of the class shaking and sweating. You're at home, so you're in a more relaxed environment, and you can educate us on a topic of your choice there. So that's the purpose of it. That's why we do it. Like I said, the topics and these instructions will be posted at 2 o'clock. So you'll be able to see those. You'll be able to click into the document and add your name. And then you'll have a topic selected and you'll be able to get started. Keep in mind, you have about a month from now until your presentation is due. So you don't need to start it tonight, but also please don't put it off until, the day before. You can usually tell when you do that. They usually don't look as nice. So sometime between now and then, dedicate some time to work on that. All right, if there are no other questions about that, and then we will go ahead and talk about homework. So your homework for this evening is going to be the workbook chapters for the workbook chapters for chapters that we went over today, so 11 through 14. Pair those along with your reading. That'll help you to fill in those blanks. Workbook chapters 11 through 14 will be due on Monday. We'll go over the answers then. Also, please keep in mind your modules 1, 2, 3, and 4 need to be done. Module 2 is fixed. So if you had an issue with that one, I apologize. It is now fixed. I don't know what in the world happened with it, but the school was able to get it situated. Also, since modules 3 and 4 weren't showing up yesterday, we did go ahead and extend those, so they're not going to have to be turned in until the 20th now. So if you need more time, you have a little more time. If not, you can still turn them in today if you want to enjoy the rest of your weekend without any schooling. Any questions on what you need to do for homework between now and Monday? Yeah, Valerie?
If we decide to do a group work, do we just put both of our names down next to a topic?
Yes. Yes. So if you want to do your presentation together, maximum group size is 2 people, and you would both just put your names down next to that same presentation topic. And if you are looking at the sheet and you want to do something with a partner, you can on Monday, if you don't know that partner outside of school, you can get their phone number, their email address during class. That's fine. Due to what's called FERPA, which is basically HIPAA for students, I can't give out your phone numbers and emails. You can give them to one another, but I cannot say, here's, Valerie's email. Can't give that to you. So you can also post in the stream area of your classroom if you wanted to talk to classmates or say, hey, I want to work with you. Here's my phone number. Are you interested? That's fine too. So if you come across that, you can feel free to post or just ask on Monday. Any other questions? No? All right. Make sure you're all here. And you are all here, and I see all of you. So if you don't have any other questions, then you're free to go. We will resume where we left off on Monday at 9 o'clock. Enjoy your weekend. Hopefully you all get to enjoy something besides schoolwork. Take a break. Do something outside. I'll see you on Monday.